Rest protocol. Next protocol we're going to cover congestive heart failure and pulmonary edema. This one's changed pretty significantly, so much in fact it's not even laid out the old way. When they wrote it, they laid it out in the new format. So just keep in mind, EMTs and advanced EMTs, you can only do stuff that's within your scope of practice and nothing above that. So we'll jump right in here real quick. So indications for this protocol is a respiratory distress patient with one or more of the following: a clinical appearance of volume overload, so uh, sounds like rails when you listen to their, or crackles when you listen to their lung sounds. They can have some peripheral edema. Um, so yeah. Uh, Suspected flash pulmonary edema or diffuse rails on exam. History of CHF with symptoms that feel similar. And a history of suggested volume overload. So somebody that missed dialysis, or they feel like they're drowning when they lay down. Contraindications: systolic BP less than 100. So in that case, you would consider cardiogenic shock, fever, or other infectious symptoms, or distress felt to be more likely to be COPD or asthma. So. Moving on to the treatment, so general care for these patients is going to be supplemental O2 titrated to maintain an SpO2 between 94 and 99. That's important. You don't want to get them above that 99 mark because, like I said in a video previously, um, once they get up to 100%, you don't really know what their actual uh, arterial sat is. It can go greater than 100. So SpO2, you want to try and keep it between 94 and 99. You want to obtain a 12-lead EKG. So EMTs, you can obtain an EKG, you just can't interpret it. If you obtain an EKG, just make sure you transmit it to St. Joe. Assess lung fields. Wheezing may be due to either CHF or obstructive lung disease like COPD, asthma. So a professor I had in paramedic school once told us that if you have an elderly patient and they are wheezing and they don't have a history of COPD, then that wheezing is considered to be fluid in the lungs until proven otherwise. So just keep that in mind. One thing I do want to note on this protocol is it says to monitor end-tidal CO2. So any patient you feel like could be a CHF pulmonary edema patient, you should have a end-tidal nasal cannula on them. I highly recommend putting end-tidal on every breathing difficulty patient. So just keep that in mind. The protocol also notes a normal to elevated end-tidal CO2, so anything 40 and above in a patient with respiratory distress can be a sign of impending respiratory failure. The presence or absence of peripheral edema does not rule out pulmonary edema as a cause of the respiratory distress. So just because a patient has super swollen extremities doesn't mean that they do or don't have pulmonary edema. It's probably something you're going to have to actually listen to their lung sounds and probably get confirmed with the x-ray at the hospital. So how medications to treat these patients. So nitroglycerin is going to be based on the blood pressure. Previously, we were just doing 0.4 sublingual like we were with the chest pain protocol. Now it's a little bit different. Now, if they have a systolic blood pressure above 160, you can give 2 sublingual nitro, so a total of 0.8 every 5 minutes up to 3 doses. If their systolic is less than 160, you just do the normal 0.4 nitroglycerin every 3 minutes up to 3 doses. So let's run this scenario. If we have a patient that we suspect has congestive heart failure or pulmonary edema, we check their blood pressure and it's 170 systolic. We give them the 0.8 of nitro the next time we check it if it's less than 160. So let's say we check it and it's 158 systolic, then we give 0.4. So that's kind of how you go about doing that. Advanced EMTs, you guys can do this. Sublingual nitro is in your scope of practice. EMTs, this part doesn't apply to you. I know you can give it to them if they're prescribed for chest pain, but this part doesn't really apply to you. Moving on. Make sure you reassess their blood pressure prior to redosing. If you're at a service that carries nitro paste, you can do nitro paste. It's kind of blood pressure dependent as well. If you're at a service that can carry IV nitroglycerin, um, you can do the IV nitroglycerin after loading with oral nitroglycerin. Um, Also, again, like always, avoid nitroglycerin if they've taken an erectile dysfunction med in the past 48 hours. Um, the protocol strongly encourages considering non-invasive positive pressure ventilation, so CPAP or BiPAP. Previously, you had to have a sat less than 92 on an auto breather to consider CPAP. That's not the case so much anymore. If you load them with nitro and they're still in respiratory distress and you suspect they have congestive heart failure or pulmonary edema, um, you can still give them positive pressure ventilation um, to help alleviate their symptoms. It kind of helps push the fluid out of the lungs, if you will. It kind of helps redistribute the fluid, is I think the way the protocol words it here in a minute. Um, EMTs, this is in your scope of practice now, so you can do this. So yeah. Um, Protocol also notes, like previously, you couldn't give it to them if they had give CPAP to a patient that had an altered mental status. It notes that you can do it if they have a slightly altered mental status. Just be cautious and make sure they can follow directions. Um, Many times they'll have improvement in their mental status once their hypoxia or hypercapnia is corrected. Um, just keep an eye on it. If they start vomiting, take it off and suction, and then try to manage your hypoxia in a different way. If you need to uh, assist their ventilations, if the patient doesn't tolerate CPAP, BiPAP, or is severely hypoxic, consider using the BVM. Make sure you're using the two provider technique, so two hand grip, use a PEEP valve, set it to at least 5. You guys the BVMs in the red bag are going to come preloaded with PEEP and M title. We're going to try to start doing that with the ones on the back of the stretcher as well. So it should already have a PEEP valve on it. Just make sure it's set to 5. If you can set it to 7.5 for this type of patient, that's probably better. And also consider using a regular nasal cannula flowing at 15 liters underneath the mask to actively generate PEEP as well. Make sure that's a real actual nasal cannula, not an end-tidal nasal cannula. The flow rate at the end of the end-tidal nasal cannula is much slower. It will only go up to like 4 liters because one side is for sampling CO2. So if you're doing the 15 liters nasal cannula, make sure it's a regular nasal cannula. Um, Patients will often receive the most benefit pre-hospital through afterload reduction, through nitroglycerin, and positive pressure ventilation. So previously we were given Lasix and morphine. Uh, they don't really have much benefit pre-hospital and can actually make things worse depending on your patient's kidney function. So we're really trying to get away from that. It takes it out of the protocol completely. And yeah, just nitroglycerin and positive pressure ventilation. If you have a patient that you suspect is non-cardiogenic pulmonary edema, they are likely to not benefit from nitroglycerin as much, unless they have a super high blood pressure. So they probably will benefit most from positive pressure ventilation. If they have some wheezing, you can consider a duoneb per the COPD or asthma protocol. So just keep that in mind when you're treating these patients. If you have any questions, just reach out.